Thank you, Surgeon General Adams. As Dr. Adams said, we will begin this convening with the business case for hypertension control. Communities that have achieved high levels of hypertension control have had strong involvement by their business sectors. Mike Cropp, the CEO of Independent Health in Buffalo, joins us now to provide a case that will help us communicate with business leaders and persuade them that business has a stake in increasing community hypertension control. Dr. Cropp is a member of the board of directors of the Alliance of Community Health Plans, America's Health Insurance Plans, and the National Forum. Welcome, Dr. Cropp.
Thank you, John, for that kind introduction. And it's really a privilege to be able to share some thoughts on this important topic. I think we've all been really impacted by what the pandemic has shown us about the risk factors for heart disease and stroke, in that they are the same risk factors for serious illness that was impacted by COVID. And we saw the disproportionate effects in populations of color when COVID hit that reminded us that those populations have higher incidence of uncontrolled risk factors for heart disease, which parlayed into higher risk for COVID as well. And that really opened our eyes up to the gaps that are out there that potentially can and should be closed in terms of managing the risk factors of heart disease. And I want to talk specifically about hypertension as one of those important risk factors, because I think before the pandemic, there were some studies that really took a look at some of the significant risk factors of heart disease and showed what the economic costs for the poor health of not controlling those risk factors were, looking specifically at two communities, FTI and a division of FTI called the Center for Health Economics and Policy, looked at Nashville and looked at Buffalo, New York, and found respectively that the overall costs of poor health related to the risk factors of hypertension, diabetes, and depression were roughly $1.6 billion in Buffalo and $2 billion in Nashville annually. So the opportunity to really address the risk factors of hypertension and diabetes represents a huge economic upside for communities, for employers, as we look at that data. And then as we take a look at what the pandemic showed us, we can see that this is not only a huge upside for an economic opportunity for communities and employers, but it's an opportunity to close the inequities that have existed across populations. Now, if we take a look at a couple of great examples as we look back specifically at hypertension control, there was a partnership that took place in Cincinnati, Ohio, between a grocery chain, which employed pharmacists, and others in the community to address hypertension as a risk factor. And as a result of those interventions, where the pharmacists were given more of an opportunity to help patients learn how to self-monitor their blood pressure, the rate of uncontrolled hypertension in that population dropped from 48% down to 30%. And as an added plus, there was an average annual savings of over $400 per individual who brought their blood pressure under control. So strong evidence to show that there is a powerful economic return, not just for a community or an employer, but for individuals as well. Rochester, a slightly different experience in terms of a community approach to addressing hypertension, particularly in populations that were at greater risk. And through their work, they found that 9 out of 10 folks who worked with an educator in the community were able to bring their previously uncontrolled hypertension under control. So we know that the Surgeon General has recommended that there is a great opportunity going forward for us to be able to increase the number of folks who are employing the right techniques for self-monitoring their blood pressure for greater control. And there have been great publications that were developed by the CDC as tied to the Million Hearts campaign, where there is a self-measuring blood pressure monitoring action plan for public health professionals and a similar self-measuring blood pressure monitoring action plan for clinicians. And as we see now that CMS has begun to authorize billing codes for providers to be able to engage their patients in self-monitoring of blood pressure, the literature showing that the self-monitoring of blood pressure can make a significant impact in bringing more people under control. Now clinicians have an added economic incentive to be able to address that. So I think the forces have lined up beautifully with the evidence to show that self-monitoring is effective, and the economic case, be it at a community level, an employer level, or a provider level. All those economics are strong to suggest that we need to move forward to engage more people in the self-monitoring of their blood pressure to bring more people under control.